Well, thank you everyone for joining today's call. Whoops, slideshow. We're very excited to have Dr. Tapper here and Dr. Rosenthal joining a little bit later on to talk about liver disease and retinopathy, respectively. Here are the steps to claim credit for CME and CE. So first, if you text 83340 to the number on the screen, this activates your online evaluation in the portal. If you don't do it, you're still going to get the evaluation. It will just be a little bit of a delay until we get attendance sent over to Corwell. So your next step on that is to complete the online evaluation by June 29th. Here is a list of our disclosures for the meeting. And then we have CE credit available for medicine CME, nursing CE, pharmacy CE, and dietetic CPEU for 1 hour for today's presentation. And with that, we're so excited to have Dr. Tapper here. He's an associate professor in the Division of Gastroenterology and Hepatology. He is academic chief of hepatology, and his primary goal is to empower patients to enjoy a high quality of life. He's an expert in the management of chronic liver disease, performance of clinical trials, and big data for the study of liver disease. He has also developed strategies that reduce symptoms and improve quality of life, and invented tools that have helped patients keep patients with cirrhosis at home and away from the hospital. He's also the editor-in-chief of Hepatology Communications. Dr. Tapper, do you want us to share your own slides so that you can go click through them on your own? I'm happy to stop and turn over sharing to you.
Okay, perfect. Well, thank you very much for having me, and I'm going to take it away talking about NAFLD, or what's now called MASLD. This is the liver manifestation of the metabolic syndrome, and to that end, we're going to talk about how we would diagnose it, how we would provide a prognosis, and then I'm going to close with some treatment. Of the conflicts that I have, the only one that's really pertinent is Madrigal, who makes the drug resmetirom, which is currently the only FDA-approved drug, but we'll put it in its right context and within its FDA labeling as we discuss it in that last slide. So I like to start by telling you a story that informs how we ought to be diagnosing this condition. And the story has to deal with a patient who is middle-aged. She went to her primary care with abdominal pain, particularly when she had spicy foods and coffee. She doesn't drink any alcohol. She has medication-controlled diabetes, metformin only, and she has a BMI of 37. So she got a bunch of labs. These were the same that they've always been and have been interpreted as normal. Because of the pain, she got an ultrasound. Her liver was bumpy. And therefore she was referred to GI, and GI did what GI always does. They ordered a ton of tests, and one of the tests comes back as positive, an ANA of 1 to 1280. We're worried about autoimmune hepatitis. She got a liver biopsy, and the biopsy is read locally as cirrhosis with lymphocytic inflammation. She started on good treatment for autoimmune hepatitis, prednisone, azathioprine, but unfortunately her liver enzymes go up. She gained a bunch of weight with the prednisone. She becomes increasingly irritable, can't sleep, she's depressed, and she's requesting a second opinion. So imagine, if you will, as I see her in the second opinion setting, that there was no biopsy. I would summarize her as a 65-year-old woman with diabetes, obesity, probably cirrhosis, an elevated ANA, but an otherwise negative evaluation. Although people order all these tests all the time, it's very important to recognize that having an elevated ANA is very common. And even for people who have NASH or MASH, which we'll get to, having a positive ANA is not associated with the incidence of autoimmune hepatitis, and it's not associated with more severe liver disease at the time of diagnosis. So I have the biopsy reread here, and at the University of Michigan, we have Olympic level hepatopathologists, and they tell me that while there is a lymphocyte, it appears to be just caught in transit. There is certainly not lymphocytic inflammation consistent with autoimmune hepatitis. So now the biopsy is not conclusive. So I would imagine just blind myself to the fact that there was no ANA, and I would summarize that this is a woman who's 65 years old with diabetes and obesity. These are the risk factors for NASH, and I am comfortable so long as I've excluded things like Hep C, Hep B, and alcohol. I'm comfortable telling her that she has NASH or MASH cirrhosis. I take her off of the prednisone, Her ALT normalizes. She loses the 10 pounds, loses 10 of the pounds she gained. She's happy. She thinks I'm good at what I do. And it's very important to recognize that although people order these tests, they don't necessarily change the diagnosis. Diagnostic testing for liver disease is often like sticking a your hand in your quiver and throwing everything at a board and seeing what sticks. But there's all of these blood tests for all these various super rare diseases, but there's no positive test that will tell you whether or not your patient has fat in their liver. In order to make sure I know that I'm dealing with steatotic liver disease or fatty liver disease, I will check for Hep C. The CDC commands it that we screen for it. Particularly in high-risk people, I'll look for hepatitis B. And I'll think about whether or not this person is drinking alcohol. I'll ask them about alcohol, but I'll also use biomarkers. And I think I just want to get across this point here, that although you see fat in the liver, and although the patient may have risk factors for non-alcoholic or metabolic dysfunction associated steatotic liver disease, it's very important that we, at some point in the diagnostic evaluation, exclude the presence of alcohol as the cause. So in one of the fanciest liver centers in the world, these people are very famous for their studies of NASH or NAFLD in Austria. They went back into their own biobank and tried to figure out which of the patients these hepatologists diagnosed with non-alcoholic liver disease actually had alcohol biomarkers in their urine, their blood, and their hair. And the answer was 1 in 4. And so if we're just relying on history, no matter who's taking that history, we're not identifying people who are at high risk. So the test that we use as it comes down to the true differential of most of the common liver diseases that we see in clinic, the test that we use is phosphatidylethanol. A level greater than 20 is associated with significant alcohol intake. And there's really no such thing as a false positive unless that person got a blood transfusion from someone who was drinking, which comes up every now and then. If you ever order this test, you just got to remember a couple of things. Number one, that the level will go down after they've stopped drinking. So here's a graph where they gave med students some alcohol to drink, some vodka, 4 shots of vodka and fruit juice. They said that they hadn't been drinking for weeks. It went up to about 120, and then it took about 7 days to normalize. And you'll notice that on the y-axis, it doesn't always start at 0, because unlike these medical students, path doesn't lie. The most important thing to remember is that you might find fat on an ultrasound or a CT scan in 41% of the people who have been looked at for a cause of their elevated liver enzymes. That's the number. But if you go to liver biopsy after all of those blood tests are negative or unrevealing, at least 3 in 4 of those people will have fat on their biopsy. And so we just don't have a test that's going to tell us whether or not that person has fat in their liver. And I'll get to the baseline probabilities. So this patient who came in with abdominal pain but went on this wild goose chase around liver disease had, and always did, had risk factors for fat in their liver. And we probably should have thought about whether or not they had cirrhosis up front. And here's why. So we can get into why people have changed the terminology, but we wanted to have a positive term rather than non-alcoholic fatty liver disease. And the word fat was felt to be stigmatizing for at least some patient interest groups. So because people wanted to publish a lot of papers about the process of getting a new name, or because that they were looking for more patient-centric language, no matter what the motivation was, they came up with this new term. Metabolic dysfunction associated steatotic liver disease. At least 60 million Americans have this, many of them obese or have diabetes. And within that frame, within that giant circle, there are some people for whom that fat has caught on fire. Steatohepatitis, those are people that we call MASH. And it is the people with MASH that can progress to cirrhosis. But what are we interested in knowing when we diagnose this condition? So this is a study from the late, great Paul Angulo. And what he showed in the Mayo Clinic is that when you biopsy somebody and you look at how much inflammation or fat or fibrosis they have on the liver biopsy, irrespective of the presence of inflammation, the only thing which governed the risk of liver-related events in the ensuing 20 years was the presence of advanced fibrosis. So on a staging system, 0, 1, 2, 3, 4, where 4 is cirrhosis, it was only the people at baseline who had stage 3 or 4 that would go on to develop liver-related events. So it didn't matter if there was inflammation there. And so Well, at one point we said you needed a biopsy to be sure about the presence of inflammation and the like. The reality is the liver disease burden for a given patient is now binary, advanced fibrosis or not. And we have tools that are available to us that are preferable to a liver biopsy. And we have to build up our toolbox if we're going to efficiently identify who amongst our patients is at risk for liver-related events. The first tool, the one that I recommend today, the one that the Liver Society recommends, the GI Society recommends, and the AACE, College of Endocrinology, recommends, is the fibrosis 4. It's a continuous value. It's based on four things: age, duration of illness, platelet count, which is the hepatologist's CBC. The lower the platelet, the more likely they are to have cirrhosis. And the ratio of the AST to ALT, where the higher the AST, the more likely that person is to have cirrhosis. You put these into MD Calc after you Googled Fib4, and it will tell you what the right cutoff is. And if you want to remember it, it's 2.67. That's high. And what's not high? 1.3 or so. But I would just recommend Googling it, and it will tell you the age-based cutoffs for this condition. The other tests that you need to be aware of are called elastography, where we determine the stiffness of the liver. And the one that we have in clinic, then that's open access to anybody to use. You can just order it, and it can be done and interpreted by a hepatologist as vibration controlled transient elastography, trade name, FibroScan. You jiggle the liver through the skin, and the ultrasound reconstructs the jiggle wave and correlates it with liver stiffness. And it gives you a continuous value. And we'll tell you in the report if that value is consistent with advanced liver disease or not. But this is an acquisition by MRI, by ultrasound, which is done at a fixed length from the skin. And so for people with a lot of chest wall adiposity, it's not going to work. So around a BMI of 40, we have a lot more technical failures. The most important thing to remember about FibroScan, beyond the selection of the patient, usually around a BMI under 40, is the rule of fives. So 5 is normal, 10 is not normal, 15 is cirrhosis for all intents and purposes. There's going to be some false positives, particularly if they have a very high ALT or they've got really bad heart failure. 20 is cirrhosis. And 25 is so stiff that there's a 2 in 3 chance that the person not only has cirrhosis, but they have portal hypertension. So 5 normal, anything over 10, and what you'll start to see in the literature is criteria for referral to hepatology is something over 8 or 10, because they're trying to capture these people who we are worried could have liver disease, although many of these people, at least half of them, will not have advanced fibrosis. And for those people with high BMI who are not candidates for vibration controlled transient elastography, there's magnetic resonance elastography. The pictures are beautiful. It's but it's not more accurate for the determination of cirrhosis or advanced fibrosis or not. It's measuring different areas of the liver. And the number here is different. So again, you have to rely on the interpretation of the radiologist. So 5.9 here is really bad. So around 3.6 or 4 is when it starts to get bad. So there's no equivalence in the values that you get from MRE or FibroScan. So how do we put these together? Walking into your clinic, a person with diabetes in the United States has around a 3% pretest probability of having advanced fibrosis. There are 2.2 million Americans with cirrhosis and 5 to 10x that who are walking around with advanced fibrosis. So it is not uncommon. And yet we can't just go around screening everybody for liver cancer. We need to be certain that they would benefit from a liver clinic or liver-related interventions. So the first step is to do a high Fib4, and that makes you a little bit more certain, but that test is not perfect. And then if you have a positive Fib4 or a non-low Fib4, then you would go to a FibroScan. So this patient, although her labs are normal, she had a borderline low platelet count, about 120, and her AST was greater than her ALT. She had a Fib4 of 2.85. She was definitely not low risk, even though the values in the chart were black, not red. Fib4 even when it's FIB4 is a pretty good test to identify someone who's at risk, and it's also prognostic. So this is how powerful this test is. Each snapshot here is from a different population-based study. Up on the top left is the Midwest, the top right is Sweden, and the bottom is the national VA study. And so when a patient with fat in their liver has an elevated FIB4 or diabetes has an elevated FIB4, that is a person who has a higher cumulative incidence of liver-related events. And if you go to the national VA study, even people who are diagnosed with cirrhosis at the bottom, if they have a normal FIB4 or a non-low FIB4, they have a much lower risk of developing liver cancer. But if you find cirrhosis like a bumpy liver and a high FIB4, that is the person that has the highest risk of liver cancer. And so if you're wrong, right, that they might have cirrhosis, but you didn't do anything else after that normal FIB4, that person is still at very low risk. So that's why it's a very safe test to apply to whole populations. So I showed you the sort of cups of certainty. I just want to show you some of the math. So because FIB4 has age in it, the Bayesian properties of this test vary as the patient gets older. Being 100 years old will give you a high FIB4. So if you start at about a 2 to 3% pretest probability from the average clinic, and then you apply the FIB4, you're going to get a post-test probability that is variable based on the patient's age. So the average 45, 50-year-old person who has a high FIB4, you're already starting at about a 60% post-test probability that this person has advanced fibrosis. But the older they get, the weaker the performance of this test. So you really see how, as you're applying this to an older population, you have to do another test. And based on the test characteristics of magnetic resonance elastography or vibration-controlled transient elastography, you can arrive at a place that approximates clinical certainty. And it is for this reason that in hepatology clinic, we'll use these sequential tests as a way of assigning people into the buckets of high risk, advanced fibrosis, or not, even without a liver biopsy. The way that I put this together with my colleague Dr. Nihar Parikh, is we take people who have risk factors for liver disease, obesity, type 2 diabetes, alcohol use disorder, certainly if they have hep C. If you see spider angiomas on an exam, by all means, think about liver disease. Apply the FIB4. You start to think about referral for additional testing if it's not normal. So we use a cutoff of 2 for people over the age of 65, 1.3 if they're younger. Then we look for FibroScan. We're looking for a 15 on FibroScan or a 5 on magnetic resonance elastography. If they're concordant, we will brand them as having cirrhosis and do the cirrhosis things like screening for liver cancer. If they're discordant, maybe we'll do a tie-breaking test, maybe a liver biopsy, or maybe we'll make a decision based on the patient's comorbidities and preferences. That's okay. You phone a friend and we work it out together with you, the hepatologist, and the patient. So in terms of the overall treatment, which I'd like to close on and leave some time for questions, the treatment of MASLD, NAFLD, goes like this. So let's say your patient does not have advanced fibrosis. This is a person who just needs to lose weight. And they can lose weight through whatever means possible. It's all going to achieve the same thing as regards the liver. So in my clinic, I just focus on low carb diet and send people back home. We love to see GLP and its friends used in these patients. And weight loss surgery also prevents the progression of liver disease. And the numbers to remember here is that at about 5% body weight loss, the patient will experience improved health-related quality of life, and they will start to see a resolution of the fatty infiltration of the hepatocyte. At around 7.5% body weight loss, you'll start to see not only a resolution of the fat in the liver, but the inflammation in the liver. And greater than 10% body weight loss is when even people who have fibrosis, F2 fibrosis or F3 fibrosis, those people will see improvements in their fibrosis burden. There was recently an abstract for a trial of one of the third generation GLP-1 drugs. And in these people, they had compensated cirrhosis, and they achieved an average of 10% body weight loss on the trial, and had a 25% chance of reducing their stage of liver disease from stage 4 down to stage 3 or lower. So that 10% is for fibrosis. If they have cirrhosis or advanced fibrosis, you think about treatments in terms of whether or not they are compensated or have portal hypertension, varices, severe thrombocytopenia. I think I think if they don't have portal hypertension, anything goes. It's the same rules around weight loss, and this has been shown in clinical trials for the next gen GLP-1 drugs. But definitely a patient with compensated cirrhosis ought to be referred to hepatology. That's definitely the person that we see in clinic. But the person with portal hypertension, you don't see too much good news coming when they start losing a lot of weight rapidly. And so that's where we have to be very careful to ensure that they don't become sarcopenic or decompensate with ascites. There's one FDA-approved drug for the treatment of MASH, and again, this is made by the Madrigal. These are guidelines for how to follow the patient or choose the initiation of the therapy, published in Gastroenterology and led by my colleague, Dr. Vincent Chen, director of the MASH clinic here at the University of Michigan. So if the patient has very high liver stiffness, greater than 20, or MRE greater than 5, it's not recommended that you start. It's not going to treat people with severe alcohol use. That is what needs to be addressed, and that's why even for people with diabetes and obesity, you're still looking for phosphatidyl making sure that that's the intervention that the patient really needs. And then if the patient has a sweet spot where they have liver disease with fibrosis, liver stiffness 8 to 15 on a fibroscan or a biopsy, that's F2 to F3, that's where it's recommended that the patient initiate resmetirom. But I don't believe that we should just be throwing this medication around, even if that patient meets that criteria. So, and I'll get to how I sequence therapies in a later slide. It's then recommended that you follow patients on this medication to see how things go. If they don't improve their liver stiffness, then that's a failure, stop it. And then if they do improve, this guideline from my colleague says to continue the continue the resmetirom. But I actually don't see why. To me, a massive improvement in liver stiffness is itself a stopping rule. Because what you should have done from the beginning or all along is address the underlying process that was driving the liver disease. And so this is how I would put it together. You take a person with diabetes, negative phosphatidylethanol. If they have an elevated BMI and they don't have any evidence of advanced fibrosis, that's a person who just needs weight loss. They're not a candidate for resmetirom. They don't need a hepatologist. If that person has elevated FIB4, elevated liver stiffness, that's a person who needs weight loss carefully, but also referral to hepatology for consideration of liver cancer screening, or maybe even screening for varices. But if the patient has improved their BMI with an intervention from 36 to, say, 25, and they still have residual evidence of increased liver stiffness or a high risk for advanced fibrosis, that's the person where not only are you considering cirrhosis type screening, like ultrasounds to look for HCC, liver cancer, that's the person where resmetirom probably shines in sequence after treating the underlying liver disease. And those are my prepared comments. And if there's any questions, I'd be happy to take them.
Yeah, I had a question, if you could hear me.
Yeah.
So what were the poor outcomes in people with portal hypertension that were put on GLP-1s? Was it just the sarcopenia or was there something else? Can you
So, okay,
elaborate?
Yeah, okay. Point one is hasn't been studied in these people formally. Point two is I'm just reporting to you what I see clinically. That a patient with cirrhosis and portal hypertension is sufficiently advanced that I don't want that I've only seen rough outcomes when they rapidly lose weight. And for reasons that I don't fully understand, I've seen a lot of incident ascites. So this is my sort of opinion. This is just opinion. But I think anybody would say you just want to be careful once they've established portal hypertension with varices. So yeah, you got to take what I just said with a grain of salt. The question about rule of fives. So the reason, so you'll always get an interpretation if you order a FibroScan vibration controlled transient elastography, but it's worth remembering. 5 is normal, okay? 10 is not normal. So if it's less than 10, we're happy. If it's greater than 10, there's about a 44% chance that your patient has advanced fibrosis. So we've identified a potentially high risk group, but we're not sold that they have cirrhosis. After 15, that's when we start to think cirrhosis. We could still be wrong, but we found a high risk group of people. Around 20, we are convinced that the patient has cirrhosis, and there's a chance that they have portal hypertension, particularly if their platelets are low. And at 25 or greater, the number goes up to like 75 on the machine. At 25 or greater, we're now so worried that they have cirrhosis, they could in fact have portal hypertension. You might not see varices on a CAT scan or an endoscopy, but the blood flow through their liver is sufficiently impeded. And the FibroScan at which the FIB4 at which I would recommend getting a FibroScan is greater than 1.3, which is the low cutoff. So if you go to MD Calc, it will tell you 1.3 is anything lower than that, you're good to go. Okay. Or greater than 2 if they're over the age of 65. And remembering age-based cutoffs is tough. Luckily, it's also baked into like the things that you find if you Google FIB4. There will be little flow charts to remind you of that. So if you only remembered 2, you've got it made, right? The people between 1.3 and 2, they might benefit from a FibroScan, but prognostically everything is going to be fine for a very long time. So 1.3 if their age is less than 65, 2 if their age is over 65. That's when you start to think about FibroScan. Thank you for the question.
I had another one if it's okay. So I have a lot of like 40 to 50-year-old men who drink too much and have high BMIs. And they're the ones that I often will see, they've got a combination of alcohol and fatty liver disease as well, because they've got two risk factors. And so, they're the ones that I see diet, 50 to age 60 from liver failure. And, oftentimes their BMIs are over 40. So I have been doing elastograms in them fairly frequently. Is that even worth doing in that population if the BMI is over 40, or do they require all of them an MRI? Because from my understanding, I'm going to have a harder time getting the MRI covered by insurance.
Yeah. Okay. So, okay, I would like to make 2 points because one, there is this disease entity called MET-ALD. So if you see it around where people want to create a new disease entity that is a combination of the metabolic risks and alcohol. But the truth is, alcohol is so much worse than metabolic liver disease. It will chew through the liver so much faster. So the key is to identify if someone is drinking, and no matter what you do metabolically, it is the resolution of the alcohol injury that is going to save their lives in the long run. The second thing that you bring up is that I said around BMI 40 is when I start thinking about MRE. If you get a FibroScan or vibration controlled transient elastography in that population and you get a valid result, you're good. Don't worry about it. It's just that the odds of getting a failure, and it's not that the value is not trustworthy. It's that they'll literally tell you, I can't get a value from this patient. The odds of getting a failure are higher. So it's about 15% max that you won't be able to get it. So if you can get a number from that, that's great. So if MRI is not covered, what are the alternatives? There are many ultrasound machines that have add-on devices that can tell you about liver stiffness. I don't trust them as much, but they're not horrible. So like it's called shear wave elastography. It's not the same thing where they're jiggling the liver. That's one. And the other option that's FDA approved is called the Enhanced Liver Fibrosis Test. It's made by Siemens. It's a send out blood test, and it will come back and tell you what your patient's risk is. And really, it's like if it's greater than 10, then that's a high risk person, which even though it's got nothing to do with the rule of fives, if you just remember 10 as the main cutoff of normal or abnormal, if you're using the ELF test, then that's what you're going to get. The shear wave elastography liver stiffness, the scale is the same as FibroScan, rule of fives again. It's just that I don't bring it up because I don't trust it as much, but it's not horrible.
Great, thank you. Yeah, obviously I'm trying to get all these people to stop drinking, but I need as much ammunition as I can to convince them. So
Yeah. Yeah, and then there's definitely evidence that knowing your liver stiffness is helpful in motivational interviewing. So we think that a patient ought to be referred to hepatology if they have elevated liver stiffness. Otherwise, a hepatologist is not great at motivational interviewing or dietary interventions, and we're not better at prescribing GLP-1s. So the ideal patient is somebody with like a liver stiffness greater than 10. Or certainly somebody with a FIB4 greater than 2.67 if you're not comfortable ordering a FibroScan. But simply having fat in the liver, there's just too many people, and they don't benefit from meeting me, I assure you of that. So we want to meet people who have cirrhosis. And then the only other thing I didn't mention is that like we just talked about elevated liver enzymes, but if like the liver enzymes are like 250, yeah, it sure can be caused by fat in the liver, but that's a scary number to meet. No, like I'm sure it would be scary to anybody. So send them my way if the numbers are scary, right? So super high liver enzymes, that's another one. But primarily, we're interested in meeting people who have a high risk for cirrhosis.
Thanks so much, Dr. Tapper. We really appreciate you taking the time to present to our group today. Clearly, it was highly valuable, and all the questions reflect that. If people have questions that didn't get answered, please feel free to email them to me, and I'll make sure to share them with Dr. Tapper, and we will get answers for you. And thanks so much, Dr. Tapper. I know you have another presentation to get to. We really appreciate your time. So now for the second half of our learning community event, we're very lucky to have Dr. Rosenthal here. She is a retinal specialist at the Kellogg Eye Center at the University of Michigan who treats many patients who suffer from diabetic eye disease. She's a native Michigander who received her undergraduate degree at Yale University and attended the University of Pennsylvania School of Medicine. She completed a residency at Wills Eye Hospital and a fellowship in vitreoretinal disease at Oregon Health Sciences University. Sorry if I didn't pronounce that correctly. She's now the Associate Medical Director of Kellogg's Clinical Research Center. She's dedicated to eradicating blindness and vision loss from diabetes through research and patient care. With that, I will hand it over to you, Dr. Rosenthal, and I'll be ready to launch those polls when you're ready to do so.
Wonderful. Thank you so much. Let me just share my screen here. And we'll start. So thank you so much. Oh, can everybody see my slides?
We could see them before, but they weren't in presentation mode, and now it's just a black screen.
Huh. Okay. Let me try stopping it. It shows up here, so I'm not sure.
Maybe you have to drag the window over. I don't know if you're using like multiple monitors.
I am. How about now?
Perfect.
Okay, great. Thank you so much. Thank you for inviting me here. I'm excited to talk to you all about the ocular complications of diabetes. And let's see. There we go. So a little bit more about the problem. Diabetic retinopathy is a big cause of preventable blindness in the US in working aged adults. That's why, we think it's so important. One estimate put the number in 2021 at about 9.6 million people living with some form of diabetic retinopathy, which was about 26% of those with diabetes, and about 5% of people with diabetes have vision-threatening disease. So the global burden of disease is around the same. All those with diabetes, about 23% have some retinopathy, and about 4% of those have vision-threatening retinopathy. We're lucky that we have several landmark studies. Some of them are multiple complications, some of them only eye disease studies, but they've really helped guide how we look at the problem, how we treat the problem, and how we look at who is going to get diabetic retinopathy. So, we know that there are several risk factors that put your patients at a higher risk for developing diabetic retinopathy. So number one, duration of diabetes, so how long they've had the disease. Really importantly is the hemoglobin A1C. We know that the higher the A1C, the more the risk of retinopathy, but also we pay attention to blood pressure, lipids, smoking can play a role, as can genetics. So duration of diabetes. There was a large study called the Wisconsin Eye Disease Study. It came out in 2000. These results came out in 2009, but they've been doing this study since the 80s. And a very, very large percentage of those who have type 1 and type 2 diabetes at 20 years of diabetes have some amount of retinopathy. At 20 years, 50% of type 1 had PDR, which is pretty high. And at 25 years, 25% of those with type 2 had proliferative diabetic retinopathy, which I'll explain in a little while, but that is one of our more severe forms of the disease, one that we really need to treat, and the one that can lead to irreversible blindness. So those who are younger when they got diabetes were more likely to have vision loss, not surprisingly, given that they likely have a longer duration of disease. The issue with this study is that it took place in Wisconsin starting in the 80s, and so it's not clear if that can really be applied to the population of this country as a whole, but nonetheless, these are some useful numbers that we look to. So this is just two ways of showing that both duration of disease and level of hemoglobin A1C at baseline really do have a role in how likely someone is to get retinopathy. So this was another large studies in the DCCT study. So you can see that those, as you go up on this screen, there's a longer duration of disease, higher A1C, not surprising given what we know. So in addition, some studies have shown, and this will come into play later when we discuss GLP-1s, but there can sometimes be a worsening of retinopathy temporarily when you rapidly correct the blood sugar. It's really unclear what your optimal rate of controlling blood sugar should be. But the bottom line is that even though it may get worse in the short term, when you get good control over your A1C, the long-term benefits are still there. So this should not preclude you from treating blood sugar and getting it down into good control, even if it's rapid. So other things that can contribute. So like I was saying, several studies have shown that hypertension is associated with an increased risk of progression of diabetic retinopathy. And, I'll tell you anecdotally, sometimes we have very hard to treat diabetic macular disease, so swelling in the center of the retina. Even though a patient's A1C is under good control, sometimes we'll check the blood pressure and, it oftentimes is poorly controlled. And so once you can get good control over the blood pressure, sometimes we can get better control over the eye disease. And that was shown in several large studies. Hyperlipidemia, patients also have a greater risk for vision loss, and nephropathy and anemia can also play a role. So, what do we tell our patients? What can we do about these? And, all the stuff that you guys are probably already doing, educating your patients on the importance of a lower A1C, improve rates of screening. Physical activity and exercise to reduce retinopathy. Smoking cessation is also an important thing to discuss because it has been associated with higher levels of retinal disease. Aspirin really hasn't had a big effect. So moving on, I am the daughter of a rheumatologist who oftentimes has complained to me about the illegibility of ophthalmology notes. And for my whole profession, I apologize. I know we speak a different language. To us, SLE is a slit lamp exam. To you, it's lupus. PVD is a posterior vitreous detachment, and to you, it's peripheral vascular disease. So, I thought maybe we'd go over a couple of notes and go over why we say what we do and talk a little bit about what happens to your patients when they go to see the eye doctor. So here's a snippet of one of my notes, and please don't be too hard on me. What's important is the second big bullet, where we grade what type of retinopathy our patients have. So this patient has moderate non-proliferative diabetic retinopathy with macular edema OU. And so I'll get into this in a few minutes, but we basically, we divide diabetic retinopathy into two main categories: non-proliferative and proliferative. And what that really means in proliferative, that means new blood vessels are growing in. And I'll explain that a little bit more. The reason we do this is because it really does stratify people based on their risk, of vision-threatening disease, their risk of, bleeding, losing their vision, all of these things. And so that's why we state that like this. Then this note says this patient has macular edema, so swelling the center of the macula of the retina. And we like to use OD for right eye, OS for left eye, OU for both eyes. And then, this person has some microaneurysms and a few dot blot hemorrhages. And they've had treatment for macular edema with injections into their eye. Similarly, this patient has severe non-proliferative diabetic retinopathy. So this is a patient that you should be more concerned about. Make sure you're encouraging them to get their diabetic exams. But again, this is sort of the mainstay of how we classify, how we stratify risk in these patients. There was a large study done several years ago called the ETDRS, Early Treatment Diabetic Retinopathy Study, that came up with a grading system that's since been modified to the International Clinical Diabetic Retinopathy and Diabetic Macular Edema Severity Scales. And they're pretty similar, and that's what we're using when we're talking about how much disease these patients have. So again, one caveat I'd like to mention, because it's near and dear to my heart, is that when we're grading this retinopathy, we are really only grading the retinal vascular disease. So whether there's hemorrhages, whether the veins are beating, and I'll show you that in a minute, whether there are new blood vessels growing. But we know that the microvascular aspect of the retina is not the only aspect affected by diabetes. The neurologic component is also affected. And, it's likely that in the near future, we'll be modifying how we grade retinopathy. But for now, this is how we grade it. So like I was saying before, we divide retinopathy into two main categories: non-proliferative and proliferative. And again, non-proliferative, or we will say NPDR, so that's what that means in our illegible notes, NPDR, non-proliferative diabetic retinopathy, is the stage where we can see a lot of changes, but we don't necessarily see new blood vessels growing in as we do in proliferative diabetic retinopathy. And I'm going to go over a little bit more about how we classify that. Within non-proliferative diabetic retinopathy, we divide it into mild, moderate, and severe. So in mild non-proliferative diabetic retinopathy, the microvascular changes are limited just to the retina, and you usually have just microaneurysms, so little tiny outpouchings of the blood vessels, and it doesn't meet any other criteria for any more severe form of retinopathy. These patients we're less concerned about. They have a lower risk of going on to have vision loss. So these patients don't need to be watched quite as closely. Versus, we'll go to the other end of the spectrum, severe non-proliferative diabetic retinopathy. And that we look at with a few things. So lots of bleeding in the retina. We divide the retina into sort of 4 quadrants. And so bleeding all over the retina of at least a certain magnitude, about 20 hemorrhages per quadrant. And in all quadrants, that would make you severe. So as you can see here, can you see my mouse? Either way, so there's a lot of bleeding in this. This is the sort of the standard photograph to tell you that this qualifies as severe non-proliferative diabetic retinopathy. Few other criteria. So venous beating in at least 2 quadrants. So this is actually a beautiful example. It kind of looks like beads on a string right here and right here. And, ophthalmologists, we call it like we see it. So venous beating is exactly kind of what it sounds like. or intraretinal microvascular abnormalities in one quadrant. So why do we classify it? Why is this important? You know, this is great. We can look at it, we can say what it is, but does it really mean anything? And the answer is yes. So, you know, if you have one of those three things I just mentioned, you have a 15% chance of going on to the proliferative form of diabetic retinopathy at 1 year, 60% at 2 years. And if you have two of those three things, you have a 45% chance of going on to have proliferative diabetic retinopathy at 1 year. And, you know, so these are the patients that we're really concerned about. These are the patients that we think it's important to follow closely because they're at risk of having vision loss. And so when you see this in our note, you know, make sure that this is a patient that you're encouraging to go see the doctor. This patient should be followed by, you know, an ophthalmologist or an optometrist. And it, you know, if you see this on a screening exam, this merits referral. And then moderate non-proliferative diabetic retinopathy is pretty much just everything in between. So it's a pretty wide category. You know, these are the people who have a little bit higher risk of going on to having vision-threatening diabetic retinopathy, but you know, we're not quite as concerned about them as those with severe non-proliferative diabetic retinopathy. So what do we do for these people who have non-proliferative diabetic retinopathy? Well, pretty much we don't really provide any treatment. You know, it's all about the systemic risk factor modification, getting that A1C down, getting their lipids down, you know, stopping smoking, making sure that the blood pressure is well controlled. Sometimes we'll do laser, but that's pretty uncommon. You know, at one point, people were looking into whether or not we could inject medicine into the vitreous cavity. And while that has been shown to reduce the level of retinopathy, it really didn't help with vision. It didn't help with anything else. And there are certainly risks involved with sticking needles in eyes. And so we don't take it lightly. I mean, we do it a lot, but we don't take it lightly. And so, you know, if we're not going to do anything, that's really not a reason to do it. Most of us don't feel. You know, sometimes intravitreal steroids can improve the level of severity. Again, not something that we do unless we really need to. And fenofibrate may reduce the progression of diabetic retinopathy based on the results of the Accord and Field trials, but there were other mortality issues with some of these trials, and one of them wasn't really powered to look at the eye findings. So, you know, most of the time it's really just about modifying the patient's risk factors, which I know is a lot easier said than done. I know our patients, it's not easy to get their A1C under good control, and you know, but that is the best thing for preventing blindness from diabetes. So that being said, we'll go on to proliferative diabetic retinopathy, and this is when we're really concerned about patients. There's new blood vessel growth in the retina. And so you'll see in our notes, we'll say NVE for neovascularization anywhere in the retina, NVI, neovascularization in the colored part of the eye, the iris, neovascularization of the disc of the nerve. That's the one we're most concerned about. These new blood vessels that grow in, they're not great. They leak, they bleed, they can shrink up. You can see here, one of them has kind of shrunk a little bit. And when they shrink, or when they grow into the vitreous gel out of the retina, that's when you can get a retinal detachment. So it can pull on the retina. This fibrous tissue just pulls on the retina and causes it to detach. And it's very hard to treat once it gets to that stage. So, you know, that's not something that we like to let get to that stage. So when we see proliferative diabetic retinopathy, or PDR, we do something about it generally. We do divide it into high risk and non-high risk, and non-high risk technically does not always need treatment. So sometimes we will watch it depending on the patient, but a lot of us will just treat it even when it's any level of proliferative diabetic retinopathy. So the mainstay of treatment is something called, you'll see PRP in our notes, and that stands for pan-retinal photocoagulation, basically lasering all over the retina, all around the periphery of the retina, lasering the heck out of that retina. Its purpose is that it destroys the retina that's ischemic. It decreases the production of factors that cause disease progression, and it'll increasing oxygen tension. So it's kind of trading one thing for another. You know, we are lasering the retina, we are causing damage to the retina, but it decreases one's risk of blindness tremendously. And so even though it is somewhat of a destructive procedure, it is our mainstay of treatment. So there are also those who are proponents of injecting anti-vascular endothelial growth factor, or you may know Avastin because it's also a colon cancer medicine, and we use other forms of this medicine as well because it also works against these new blood vessels. We're very lucky in ophthalmology and in diabetic retinopathy in particular because we have a lot of groups that do these wonderful clinical studies, and one of them is called the DRCR-NET, or Diabetic Retinopathy Clinical Network. And so one of their protocols looked at either treating with injections or treating with PRP. And they found that, yes, there were benefits to treating just with anti-VEGF, decreased need for surgery, less macular edema, because it's also actually a treatment for swelling of the retina or macular edema. But you need repeated injections at regular intervals. And it doesn't have as long a duration of effect as PRP. And as we know, unfortunately, a lot of people who have diabetes are dealing with a lot of other health problems. They're dealing with a lot of other issues or social determinants of health. And so they can't always make it to all of their appointments. And there have been several studies done that showed, outside of this, protocol S, this study where, people are calling patients, they're making sure patients are coming to their appointments. It's very controlled. A lot of these patients, when you're only treating them with anti-VEGF, can get lost to follow-up. They get lost to follow-up, they're hospitalized or something happens, they miss all their treatments, and then they can have a lot of dire consequences of the proliferative diabetic retinopathy, unfortunately. So, our mainstay of treatment at Kellogg is still mostly PRP, but oftentimes we also will do a combination. So sometimes, you can inject the anti-VEGF to get rid of those blood vessels temporarily. It makes treating with the laser a lot easier, especially if they have some bleeding in the back of the eye. So a lot of times it's now a combination, and there's some recent evidence to show that a combination may actually be the most effective way to treat this. I also have some patients that actually refuse the laser. Believe it or not, actually, patients generally prefer the anti-VEGF injections to the laser. It's quick. We numb up the eye really well. I know it sounds very scary, but it's actually not as scary as it sounds for most people. No one I've done it to has ever said, yeah, that was scarier than I thought it was going to be. And it's actually a lot easier than the PRP. So some patients just refuse the laser, can't handle the laser. And so it's nice that we have an extra tool in our tool belt. And then, of course, surgery for the more advanced forms of disease. Sometimes if there's bleeding into the back of the eye and it doesn't clear, or if patients get that retinal detachment from the pulling on the retina. So, we've talked about vitreous hemorrhage and the tractional retinal detachment, or TRD is what you'll see in our illegible notes. There's also something called diabetic papillopathy, which is swelling of the nerve in the eye. It can be on one side, both sides, and it can happen at any stage of diabetic retinopathy or glycemic control. And sometimes people see very well despite the fact that their nerve is swollen. So that brings us to one other complication called diabetic macular edema. And what you're looking at here is what we call an OCT, or optical coherence tomography. It's really cool technology. I mean, it's been out now for, over 20 years, but it's basically like making a slide of the retina without having to cut up the retina, which is beneficial because then you couldn't see. But it basically, you're looking at a picture of the retina turned on its side. So you're looking through the different layers of the retina, and it's revolutionized our ability to look at swelling in the retina, to look at macular degeneration, lots of things that we use it for. And in this instance, this is a patient who has diabetic macular edema. So normally the retina should be you should have a nice little dip in the center. But as you can see, you have these areas of black here, and those are areas of fluid in the retina. So it makes it really easy to diagnose. And if it's affecting the retina, we actually have some very effective treatments for it, which is really great. It basically results from the breakdown of the blood-retinal barrier, which is similar to the blood-brain barrier. And then this fluid just extravasates into the neurosensory retina. And as you can imagine, if there's a lot of fluid right in the center of your retina, which is where you have your most clear central vision, it's the vision that you use to recognize faces, see things up close, and read, that's going to affect your vision. And importantly, it can happen at any point along the spectrum of disease of retinopathy. So patients with mild non-proliferative diabetic retinopathy can get it. Patients with proliferative diabetic retinopathy can get it. It doesn't discriminate. So what do we do for that? So this is where we see your patients a lot. You know, your patient may be coming to see me every month for treatment because the mainstay of treatment is intravitreal injections. So that same thing I was talking about for proliferative diabetic retinopathy, we inject mostly anti-VEGF, so Avastin. You might see advertised on TV, Eylea HD, or Vabysmo. We have a lot of medications now to choose from. We usually start with Avastin. If none of those work, we can also inject steroid, but it has other side effects. So for most of us, it's not our first line treatment, and it can work really well. I mean, it really can restore vision. The downside is it needs to happen more than once. It's not a permanent treatment, just like it's not a permanent treatment for PDR, proliferative diabetic retinopathy. So this is a big reason why we're probably seeing your patients a lot when they have macular edema. And again, it's great because it works, but they have varying durations of effect. Usually, Avastin, we start off with doing it every month. But again, it's one of those things that sounds very, very scary. It's not as scary. I realize it's easy for me to say because I do this all the time. But my patients do tend to back me up on that. Other things you can do is laser. It's become less common to do laser because that was sort of the old way we used to treat it before we had these injections. We would sort of lightly laser the center part of the retina. As you can imagine, laser is destructive. We don't do quite as strong a laser as we do when we do proliferative diabetic retinopathy laser. However, it can be very good if the fluid is not right in the center. If it's right in the center, we don't want to do it because we will leave patients with a big spot in their vision or scotoma. So this brings me to something that's near and dear to my heart, that's very important, because this is where, we get to work with you, where this is where you come in, because screening is the only way we can sometimes find the retinopathy early enough to do something about it. A lot of times the early phases, even when someone has proliferative diabetic retinopathy, they may still have 20/20 vision. They may not notice anything. And this is why it's so important to get patients screened. And so if I can just make one point today, that is really it. Screening, 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 because if we don't screen, we'll never know that the disease is there. And if we could have done something to prevent blindness, and we missed our shot, that's where it becomes heartbreaking. So now's the poll. So what percentage of your patients are actually able to get their regular ophthalmic screening in any shape or form? And so we'll open up the poll.
The poll's currently live. I'll stop it after we've gotten enough responses, Dr. Rosenthal, and then share it out with everybody.
Okay, yeah. I mean, they've shown in several studies, just interrupt me when you've got it. They've shown in several studies that only about 50 to 60% of patients with diabetes get their regular eye screenings. Which is pretty low. I mean, given all the recommendations, which I'll go over in a moment, but it is not where it should be. Awesome. So you guys are doing great. That is really great. So next poll. Oh. How do you screen patients for retinopathy in your practice? Do you refer them to an ophthalmologist or an optometrist? Do you take photographs in your clinic and send them to outside graders? Or do you take photographs in your clinic and use an AI camera? Or is it some combination of the above?
Okay, give people just a second or two more on this one, and then we'll share out the results as well.
Yeah, sorry, I apologize. We started a little late. I know we're close on time.
Oh, no worries, not your fault. Okay, I'm gonna end share.
Awesome, that's great. So it sounds like a lot of you are either referring or have a combination of referring and doing it in your office. And the reason I ask is, we should be screening all type 1 patients at 5 years post-diagnosis, and then every 1 to 2 years. This is for adults. Type 2 at the time of diagnosis, then every 1 to 2 years. Pregnant people should actually get screened in their first trimester. Diabetic retinopathy tends to progress faster actually during pregnancy. And so it's really imperative that these patients get screened. But for those with gestational diabetes, you actually they don't need screening. If you think about it, duration of diabetes is also important, and they haven't had it for that long if it's just gestational diabetes. This is actually something that's near and dear to my heart, but I'll go through it quickly because youth onset diabetes is actually a little more prevalent than we used to think about it. Diabetic retinopathy, excuse me, in these patients. So, the recommendations from various groups differ, but they're all about, 3 to 5 years after diagnosis, and those who are at least 11 years or undergoing puberty, type 2 always at the time of diagnosis. But new data from these large studies show that higher rates of complications such as retinopathy are present more than we previously recognized. The search study and the Today study showed about 50% of people have some amount of retinopathy at 12 to 13 years from diagnosis. So this is actually more prevalent than we used to think. And certainly with the type 2 diabetes going up in prevalence in our youth, this is something we need to pay attention to. So again, screening in primary care settings can actually be a really, really great way of finding retinopathy. These patients have so many things on their list of to-dos with doctors. They're dealing with complications. They're dealing with a lot. So it can be really hard to get to the ophthalmologist. There was one study that showed that even though patients didn't get their dilated examination with an eye doctor, 82% of them of the patients who did not get their regular screening had visited their primary care doctor. So it's a huge opportunity to get these patients screened. And it really can increase uptake, doing it right where they already are. It can take different forms, as I was mentioning before. You can get cameras that can capture images from eyes. You don't need to dilate patients. You can either take the photos, send them to a reading center, or there are now 3 FDA-approved artificial intelligence graded photos, and you can code for it. So it really can be beneficial to your practice, because I know this is also something that you are measured on, whether or not your patients get an eye screening. So you get the results of your screening, and what do you do with it? What does it mean when the machine or the grader spits back that answer? Very easy. So, patients with mild or no diabetic retinopathy, just get them screened again in a year or two. You don't need to refer mild or better to an ophthalmologist, but anything more than that, moderate, severe, proliferative, those should all see an eye doctor. And anyone who has macular edema on these screening tests should also be seeing an eye doctor. So I'm going to go through that very quickly, but you can look this up in the International Council of Ophthalmology recommendations for screening for the actual numbers. And then I know that this is a hot button issue, so I'm sorry to get to it at the end. I'm certainly happy to answer questions on it, but there's a lot of talk about whether GLP-1 agonists have dangers for the eye. Do they increase diabetic retinopathy, optic neuropathy? The answer is we don't know. The SUSTAIN 6 trial raised the alarm, but it wasn't really powered to look at eye complications. So they started another trial called the FOCUS trial that is looking at eye complications after 5 years of use of these GLP-1s. And however, the results are coming next year, so stay tuned for that. Optic neuropathy, the studies are contradictory. And, when I talk to my colleagues in neuro-ophthalmology, they're not restricting its use because there are so many other benefits for your patients, mortality, things like that are very important. And so, for something that we just don't know about, none of us are really restricting their use in patients because of the eye complications. All right, thank you. Sorry to go over a little. I'm happy to answer any questions.
Thank you so much, Dr. Rosenthal. There's one that I feel like you already generally speak to about GLP-1 medications, though they did specifically ask about macular degeneration. I'm guessing it's the same as the others where it kind of remains to be seen.
Yeah, I mean, there was a recent study that came out about that with some question about it. And so I think that has still yet to be answered with more data. But yeah, there was a recent study that raised an alarm about that too. A lot of times these studies aren't really done with enough power to be looking at the eye complications. So it's always hard to say.
The last one was, can you please review what anti-VEGF does?
Yes. So antivascular endothelial growth factor, it works against any new blood vessels that are forming, or, when the retina is ischemic, it releases a lot of factors, including VEGF. And we know that if we, give these medications and they're working against the VEGF that's being released from the ischemic retina, that it can help either shrink up blood vessels or, help make macular edema improve. So we inject them for proliferative diabetic retinopathy to make new blood vessels shrink up, and also for macular edema to decrease the swelling of the retina. And was that the question? Did that answer? Okay. It's an injection of medicine through the conjunctiva and sclera into the vitreous cavity after numbing medicine, of course.
Any other questions before we wrap up? Well, thank you again, Dr. Rosenthal, and appreciate everyone for staying on and hearing the rest of the presentation. We'll get the slides out to everyone and we'll share this recording as well. And same thing, if you have questions that we didn't get to, please feel free to email them to me and I'll make sure that they make their way to Dr. Rosenthal. Dr. Rosenthal, thank you so much for your time and sharing your expertise with the collaborative. We really appreciate it.